Okay, so a quick overview on the assessment of biomechanical assessment in the periphery. Now, if you look at this flowchart, you've seen it before. In fact, this is exactly the same flowchart you saw before for the spine, except I've gone in there and changed a few of the labels. So this should be a big stretch for you understanding this tool, so we can whip through this. So the biggest difference here is the naming. So you'll see PPM, which is okay, so we're going to talk about subluxations. In the periphery, the subluxations are a little different than they are in the spine. Just to review, in the spine we talked about this being a flexion subluxation or an extension subluxation, which probably isn't quite true. This is abnormal flexion or abnormal extension, just goes off the rails a bit because of the degeneration. In this periphery, we have an added. Okay, so a quick overview of treatment. Along the top, you can see the dysfunctions that we're going to find: pericapsular hypomobility, pathomechanical hypomobility, hypertonicity causing hypomobility, adhesions or scars, and instability. And we're going to have a quick look to see the principles of treatment of these with manual therapy. So with pericapsular restrictions, you're going to have to mobilize this, and it's going to have to be. Okay, so we're going to manipulate the joint. Now there's a couple of different ways you can do this. We're not talking about loose body manipulations, but subluxation manipulations. So we can either directly manipulate the restricted motion. For example, a carpal that's gone dorsal, we can basically thrust it palmally. Now this is generally done under distraction. Some of the biomechanics we learned previously, how to apply conjunct rotations, degrees of freedom, surface shapes, and directions of arthrokinematics versus osteokinematics. And we'll use the elbow as an example. The elbow is an interesting joint, which is code for complicated. There's obviously 3 joints involved in this. Actually, there's 4 if you include the inferior radial ulnar joint, but we'll keep it a bit more simple than that, and we'll say there's 3 joints involved here, and each one has its own biomechanics. So assessing and treating this joint is interesting, to say the least. It'll stretch you a little bit, but not terribly much. Elbow is an interesting joint, as we said before. There's 3 joints you have to consider: ulnar-humeral, radiohumeral, radio-ulnar. We're going to ignore the inferior radio-ulnar, which has to be assessed with the elbow, but for the purposes of this discussion, we're going to ignore it. It just makes it more complicated than it needs to be. So, whenever we're assessing this, you have to consider the biomechanics. For example, it is impossible to assess biomechanically the entire elbow in one sitting. You get a crack at it with the quadrant test, but it really doesn't do it completely the way we want it to be. The reason for this is that the ulnar-humeral joint has a different conjunct rotation to the radiohumeral joint, a completely opposite direction. So that if I gain full flexion, for example, of the ulnar-humeral joint, I cannot at the same time get full flexion of the radiohumeral joint. So these joints have to be assessed separately. So let's start with the ulnar-humeral joint. Structurally, this is a modified sella. It's got 1 degree of freedom, flexion and extension. Now the conjunct rotations for these are rotations of the ulna. So as we flex the elbow, the ulna will rotate laterally. Or if you prefer, full flexion of the ulnar-humeral joint requires full supination of the forearm. For extension, the conjunct rotation of the ulna is medial, that is, it puts the arm into pronation. So again, to get full extension of the ulnar-humeral joint, you have to incorporate full pronation. If you can't assess the full range, you can't assess the limited range. So these conjunct rotations have to be included. So the have an adduction component, which normally would only be considered the conjunct rotation, is so important biomechanically that it is considered as a separate degree of freedom and it's assessed as such. So functionally, this would be an unmodified sella with 2 degrees of freedom, flexion and extension, and abduction. And it's the abduction that gets affected with biomechanical dysfunction of the elbow, not the flexion extension. The flexion extension is severely bothered by arthritis, arthrosis, fractures, that type of thing, medical pathologies that causes severe limitation of movement here. But for the end range motions of biomechanical dysfunction, it's the abduction. So this has to be assessed as a separate range of motion. So the passive physiological movement assessment of the ulnar-humeral joint will be flexion supination, which requires both movements to go to its full range, and extension pronation. Now, for abduction, you will assess abduction as a passive physiological movement for the ulnar-humeral joint. For the PAN, the arthrokinematic test, flexion and extension will be an anterior and posterior glide respectively. While abduction, and that's because for flexion extension, the olecranon presents a concave surface to the trochlea, so the arthrokinematic is in the same direction as the osteokinematic. That means that abduction must be a male surface presented to a female surface, as far as the ulna is concerned. So the convex surface of the ulna will glide in the opposite direction to the movement. So abduction of the forearm of the ulna will be a lateral movement, so the glide has to be medial, and for adduction the glide has to be lateral. Now, abducted ulnars tend to be a lot more common than abducted ulnars tend to be a lot more common than do adducted, and these are often asymptomatic causes of a tennis elbow. So you've got to get used to doing this. You must assess the medial glide to see if you can get adduction. If you can't, then you have an abducted ulnar. For the radiohumeral joint, we're looking at biomechanics. So this now is structurally an unmodified ovoid. If you look at it, you'll see that it makes almost, the capitulum is almost a perfect sphere, and the radial head is almost the inverse of this with a concavity. However, it can't function as an unmodified ovoid with 3 degrees of freedom because it's attached to the ulna. So the ulna will limit its ability to go through 3 degrees of freedom and also modify what it does. So functionally, this is a modified ovoid with 2 degrees of freedom, flexion, extension, and spin. And the conjunct rotations of this is for flexion at the radiohumeral joint, you have to do pronation with the flexion in order to get the radial head as far up the capitulum as it can go. So the full range of motion test is flexion pronation and extension supination. For pronation and supination, there is no glide because it's a spin. So your test for this ability to spin is distraction. And you can either do that with the capsule tightened up in the direction that you're interested in, say pronation, and then feel the end field for that distraction and then the amount of movement, and then compare it to the other side and if you'll see the same end field and movement there. The passive physiological movements for this joint then is going to be flexion pronation, extension supination, and the glides will be superior, moving the ulna superiorly along the capitulum for flexion and inferiorly for extension, and the glide, as I say, for pronation supination is distraction. For the radioulnar joint, we're just going to consider the superior one now. The biomechanics of this is the surface shape is actually a modified ovoid. So it should have 2 degrees of freedom, but because of its attachment to the ulna, it loses one of the degrees of freedom, and basically its degree of freedom that's allowed is pronation and supination. Now, at the radioulnar joint, superior radioulnar joint, the radius presents a convex surface to the ulna. At the inferior joint, it presents a concave surface. So if you consider both of these joints together, the superior one is convex, from the radius's point of view, and it's concave in the inferior. So you have a concavo-convex surface that makes it a cellar joint. It's a modified cellar joint functionally. So it can do pronation and supination. Now the glides at the superior joint are in the opposite direction to the osteokinematic. So for your PPM is basically pronation and supination. That's it. So to glide it to see if the joint has full range of pronation, you have to consider the direction of movement of the bone. So that with pronation, the radius moves ventromedially, so the glide must be dorsolateral. For supination, it's a dorsolateral osteokinematic, so it must be a ventromedial glide of the radius there. Okay, so I'm hoping that this has given you an idea of transforming your theoretical knowledge of biomechanics into the practical application of technique. And this applies to all of the joints. You have to understand the biomechanics in order for you to do the techniques without being a technician. Sure, you can just go in there and do all the techniques we show you. Yeah, it's quite a figure of memory to do that, but if you can understand what you're doing and why you're doing it, then you don't have to remember it, you just do it. And you can also innovate, produce new techniques that are better for you and better for the profession sometimes. Somebody has to invent these techniques, and there's no reason why it shouldn't be you. Okay, so take care everybody, and I'll talk to you again. Bye-bye.